board-certified internal medicine doctor, internal medicine and pediatrics. She has led innovation across startups, clinics at Zoom Care, Zoom Plus Care, and hospital chief medical officer at Legacy Health, founder of Novella Insights. Welcome, Holly.
Thank you. All right. Thanks so much. Fantastic. Well, I appreciate the kind words of introduction, and it's really an honor and great to have everyone here today to talk about Clinic of the Future, my original concept for this. So we're just going to kind of dive right in here. Show of hands for the room. Who here works in an outpatient clinic? Do you have any? Okay, yeah, a few physicians, great. And whether or not you're working in a clinic or simply a patient or family member, do you think things are going well? Is it looking good, healthy? Like business as usual is going to be sustainable for the next 50 years, let's just say? Or conversely, have we noticed some things like high staff turnover, rising administrative burden, dissatisfaction in all quarters, unionization even? Yeah, I see some nods. So that's a loaded question, obviously. But this talk is going to be about how we got to this crazy place in healthcare, and really my proposal for how we can fix it. And working on this has helped me personally feel more hopeful and more energetic about the future. So I hope that it may do a little bit of the same for you. And in addition as well, I love feedback on this. So please just feel free to ask questions. There will be a couple question points as well. Find me afterwards, hit me up on LinkedIn, coffee's on me if we can actually do a physical coffee. Because every time I do this talk, which has been actually over the last 9 to 12 months, I change it quite significantly based on excellent input. So I really appreciate all of that. So we kind of talked about this. Is it sustainable? Kind of telegraphing the answer there with the pictures of the folks. And so as Uli kindly mentioned, I put a couple of career highlights on here just to show the different front row seats that I've had over the last 20 plus years to what I call the healthcare show. So from hospital CMO, outpatient medical quality director, etc., I've become obsessed with how we can fix healthcare, frankly. And so I really thank Paula for teeing this up because she gave such an excellent overview of the big picture in healthcare, what things are looking at the very macro level, and then this is going to be quite a bit more micro about Clinic of the Future. I think as well as has been talked about at this conference that this is a huge moment of crisis, disruption, and then also embedded opportunity if only we can seize it. And so it's not just that things are broken, which we know that they are, whether we're working in the system or experiencing it as a patient, but that we have completely new and emerging tools with which we can actually comprehensively reimagine care from the ground up and make it make sense. And then quick note, it's my original concept. I don't represent my employer where I still see patients in Portland, Oregon, and no disclosures or conflicts of interest. So basically, I'm going to posit that change is not just on the horizon, it's already here. And I don't think physicians have the luxury of sitting on the sidelines and hoping somebody else will figure out this unique moment and how to handle it. I think that if we don't step up to the moment and lead, that we are going to experience change being done to us rather than by us or for us. And it will likely be in a hodgepodge way, poorly thought out, and one Band-Aid solution at a time, which I tried to evoke with this, of course, AI-generated image of a frustrated physician in front of a computer covered with Band-Aids. Each one of those solutions, of course, makes sense to the administrator who blessed it in their silos and getting a good pitch about a problem that's being solved, but it may not make sense comprehensively. So I think Clinic of the Future gives us that roadmap rather than sort of chasing each shiny new thing as it comes out. And so what do I mean by that? This is sort of the basic summary, and then we're gonna unpack and go into more detail. Automate the mundane and elevate the human. So everything that does not actually need human touch or judgment should be done by an empathetic, responsible algorithm. If we look at the flow on the bottom, we should start with AI first, then staff in the clinic like MAs and front desk staff, then the advanced practice clinicians, so that's nurse practitioners and physician assistants or associates, depending on your nomenclature, and then up to the physician when things get hard, nuanced, need greater judgment, training, etc. I think that we need to break the visit, and we need to break the PCP, which, ouch, because I am still practicing as a PCP, so it's hard for me to say that, but I believe we need to kind of replace it with these 4 pillars here in pink. a trusted multidisciplinary team using personalized protocols to give a flow of care, not discrete packets called visits, all supported by tech. And I think if we do this right, we can be more Marcus, or perhaps Marcia, Welby MD, like the sort of old archetype of the caring family doc who had all the time in the world. I think we'll get some time back by not doing lower level administrative and burdensome things. And we're gonna have kind of a chassis of, let's see, what would I call it? Standardized care that is personalized to each patient, essentially. And why do we need to kind of redo the clinic and whatnot? It could seem a little bit mechanical, the way that I laid it out on the previous slide, or even heartless. But I actually think that the pressures have built up so much in the last few decades in healthcare that in order to safely care for the whole population, we need to do something wholesale different than what we have been doing. So now we're gonna zoom backward a little bit to understand kind of these assertions that I'm making here and go into the context. And we're gonna meet Ms. Jones of 1995. So a typical patient from a few decades ago. And she was a middle-aged woman with a couple of simple conditions, hypertension and hypothyroid, on some simple meds, getting basic yearly labs and GYN care. And she pretty much behaved appropriately in clinic, which is not something we can always take for granted right now. And she had trust in her doctor and healthcare team, and she generally followed recommendations. And basically, we did not have the explosion of My Health messages because there was no essentially internet or email. And we didn't have Dr. Google because we didn't have even any Google. And nobody did their own research unless they worked at Stanford. So you could actually see Ms. Jones, you could run on time, you could feel proud of the work that you were doing and not be exhausted. And that was very rewarding. And then of course that little image there indicates we had paper charts, and I came in at the very tail end of paper charts, so I remember them, and maybe some do in this room, which were frustrating, but we had to work at what I call the speed of paper, which did impose some sort of human limitations on the work, both the speed and the scope. But if we fast forward now to Ms. Jones in 2025, I did change her picture a little bit, just not to harp on that same poor lady on the internet, but it's meant to be the same patient and then sort of AI avatar here of a struggling doctor, if you will. So let's talk about Ms. Jones of 2025. I saw her last month. Those of you practicing may know her as well. And in addition to those same clinical elements that I described before, now Ms. Jones hasn't been seen in a couple of years. She's overdue for all the health maintenance, including needing a pap smear. But she's got concerns, and the concerns are about things like depression, just can't lose weight, obesity, wants to talk about Ozempic. Could it be perimenopause? You know, maybe I need some molecular U or other biomarkers or some of the hormone startups that I was hearing pitches for last night. So she's got all these things on her mind. And then the kicker is she comes in and she says, I mean, I don't think I have ADD, but like I can't concentrate. And when I take my son Zach Adderall, it's better. So I'd like my own prescription, please. And thank you. And so this all kind of falls on our doctor in what one audience member called the one toxic visit. You know, it's being saved up for years, and now patient comes in and kind of wants all these things handled. And then in addition, it's not just the patient who's changed since 1995. Our standard of care has gotten markedly more complex. And so now as the physician trying to do this visit, you have alerts in your EMR popping up for screening for HIV, Hep C, syphilis, depression with a PHQ-9 questionnaire, and then many more immunizations recommended than were for the average risk in 1995. So you see the patient, and what does Ms. Jones do afterwards? She complains to the clinic manager that she didn't get it all done in one visit. She doesn't want to pay 2 copays. She's on a high deductible plan, of course. And then she sends a picture over My Health about a rash that we didn't have time to talk about. And do you think that rash picture is clear? It is not clear, it is blurry. Not because smartphones don't take good pictures, but it's being held too close to her leg. So this is just sort of a day in the life of clinicians seeing patients in clinic these days. And of course, caveat, we can all have bad days and we're all patients. None of us are really at our best when we're getting healthcare necessarily. But when every visit is like this, it can be pretty unsustainable and lead to burnout for the physician. So what's going on here? Kind of a busy slide. I'll draw your attention to the House of Medicine over there that's pretty much on this cracked foundation from the weight of everything that has been put on it in the last few decades. And these are these tweaks and complexities that we've kind of bolted on without fundamentally changing the actual system. And I listed a bunch of them there. I've got don't laugh, a 90-minute version of this talk in which each one of these gets more than even one slide going into great detail, but I think you guys kind of get the picture. The standard of care, or SOC, there has risen. We've got quality metrics that we never even used to dream of, which, saying as a former quality director, I love that stuff, but it's definitely a double-edged sword. We have ask your doctor about, all of those messages that the patients get. That little prescription bottle over there is meant to evoke the opioid crisis and the controlled substance, stuff that goes along with that. Maybe the taking recreationally somebody else's Adderall is a little bit of a gray zone related to that. The MMR bottle evokes distrust, so the debunked theories about MMR and other vaccines and whatnot causing autism. And then I just want to mention, for example, STOH, or social drivers or determinants of health. Back in 1995, we didn't even understand the idea of food as medicine, really. There were just glimmers coming in on that, versus now, food insecurity is something that the clinic is responsible for addressing, screening for, no less, and then also addressing. So it just kind of shows how things have changed. And then up here, may you please speak to your manager? This is a really important thing that's affecting us these days, which is the shift from patients to customers, or even consumers. And so I posit that we have tech-enabled experiences in other aspects of our lives, like Amazon overnight shipping, DoorDash, Uber, and whatnot, that satisfy our needs near immediately, and all based on convenience and satisfaction. And then people naturally shift those expectations over to their healthcare experience. And I totally get it, because I do that too when I'm a patient. But the problem is that healthcare was never designed to be delightful, first thing, nor was it actually designed to even be fast or convenient. And then you have your NPS, Net Promoter Scores and Press Ganies, kind of driving that point home to the clinician. So just really accentuating that. And then to some degree, this leads to the exploding inbox here. So, we've had such an incredible increase in my health messages and whatnot, and we'll talk more about that too. And then I put up the anxious generation just to show the mental health changes that have gone on in society and, that we're dealing with. Okay, so what does this lead to? Again, I won't belabor these points. These are essentially physician or provider pain points, and probably those giving care here could even add others. But, all the burden of documentation, repeated conversations about the same things, answering the same questions over and over, best practice advisories, the HCC diagnosis prompts that come up in your medical record and distract you from what you're actually trying to do. Remembering to order low-level stuff, not low-level, it's very important, but stuff that should be automated, like the flu shot every single visit in winter, unless they decline. Somebody else pointed out in one of my audiences, forms for everything. So not just forms for, let's say medical leave, but the parking, the therapy animal, the power bill, the person needs the refrigerator for their insulin, and so now they get a reduced rate on their bill if the doctor signs it. Okay, so let's go ahead into clinic of the future, okay? That's kind of enough talking about the difficulties and how we got here. And we'll meet Ms. Jones, still the same person, but I changed her picture. I wasn't confident enough to project into 55, so here we are in 2035, just a mere 10 years ahead. And this is my concept of Charlie Chat Care. So I'm sure that you guys, as you've been going through JPM week here, have been hearing a lot of different versions of an empathetic AI chatbot that interfaces with the patient and solves things. And then of course we've got ChatGPT and Claude for Health that just dropped last week, and so the landscape is evolving. Although I wrote this many months ago, but I feel a little bit vindicated that now events are catching up. To be clear, Charlie is not an actual thing yet, like literally named Charlie. It just exists in my mind. But again, we have many versions. We even heard a presentation yesterday about a voice chatbot. But it probably didn't take a crystal ball either to know that we were going this way. So let's just say Ms. Jones, instead of bringing all of that stuff to that one be-all, end-all visit that was so difficult, she says all that same stuff into Charlie. And she says, weight gain, and what about Ozempic, and this and that. And Charlie starts swinging into action with more questions, collecting clinical information, doing that PHQ-9, recommends a visit, setting proper expectations for what can be done in the visit, prepping it, and then Charlie talks to Emily or again, my concept for the EMR-based AI agent, who then preps the chart, gets everything ready for the physician, etc. And so we're starting to handle things proactively in an orderly flow of care. Okay, so let's kind of pull this apart then into those 4 pillars. These are the pillars that are behind that experience for Ms. Jones in 2035. And first of all, we've got the idea of breaking the, like I said before, break the PCP and replace with a trusted multidisciplinary team. Now, there's a lot of reasons for this. I think that if we have APCs and one physician kind of leading the team and directing the group, caring for a large number of patients, could be 6,000 or 7,000 patients, depending on your size, we can really be all stronger together and functioning optimally in our lanes with strong clinical protocols, which we're going to talk about. And this would include as well the nurse, the pharmacist, the social worker, the other valued members of the teams that we have now. And why do we need to do this? I think one major reason is we're not going to have enough doctors to keep doing things like 1995. We have a looming physician shortage, thousands of physicians short predicted by the next 10 years. And as well, APCs and AI now, with AI especially getting ever and ever more sophisticated, can really do a large part of the care. And I really think that the doctor should be handling the harder, more nuanced things that require the judgment and experience, and we should all be working together to make each other better. Docs should not be doing like super low level stuff because it's really a waste of our scarce care resources. And I think it'll be a win for patients because now they'll have more trusted people who care about them. And it'll be a win for the team because when you're not in clinic, but if you trust your colleagues and you all know the pool of patients, you can disconnect and recharge, and then that will be helpful for reducing burnout. Okay, personalized protocol. So this isn't actually about food as medicine, which I already mentioned, but trying to evoke the idea of a cookbook. So letting simple things be simple, but personalized for the patient. And so I think that when we argue needlessly about low-level stuff, like, well, should we do a BMP really every year or not, a basic metabolic profile if the patient has hypertension, it saps our energies and we don't have bandwidth for more complex things, and it can actually even be confusing for patients and for our team members, frankly. We could be more bespoke back in 1995 when things were just a lot simpler and less regulatory oversight. But then we can personalize these things with the help of AI based on all of those individual factors about the patient. So risk factor calculations. If you are at higher risk for breast cancer, you should be recommended a different screening protocol for mammograms and maybe even other modalities than the average risk person. So we're going to have Emily in the chart synthesizing all of that and helping us devise personalized protocols, maybe even as things evolve with precision medicine, like from Molecular U type of information about each patient and their individual factors. We'll know their values and preferences even better because hopefully we'll have more time to make that human connection. And maybe even Emily can be prepping us on things that we might have forgotten as a fallible human, like the hobbies, the kids, the milestones, and even kind of reinforce that human touch. Then the third thing, care in a flow. So I've alluded to this already. Running on time or running late is a huge cause of burnout, frankly, right now in clinic, and it doesn't just affect the provider, it ripples out to the whole staff. So one good thing that the pandemic did for us was to show us that within the 4 walls is no longer the only place that we can deliver good care. We blew through a lot of barriers to telehealth. I think that's been a wonderful benefit of going through that experience. And so we can have a whole flow, including Charlie talking to the patient, video visits, care by message, which I'm going to talk a little bit more about. I think secure texting is coming too, in-person visits, and then even, as has been mentioned, connected devices. So information coming from a smart scale, blood pressure cuff, continuous glucose monitor that comes into the EMR. Emily, is aware of that and analyzes that, and then can actually mobilize resources to deal with the problems before they become bigger problems and maybe even result in an ER visit. So care doesn't have to stop just because the visit has to come to an end, and I think that will be beneficial and help the patient feel just wrapped in a flow of care. Now, one big part about this is the inbox too. So, I've alluded to the inbox already. The rash picture, in the vignette about Ms. Jones of today was sort of meant to be annoying and funny, at the same time, and it's so real life. But actually, I really think that messages are great. I love care via message. I love to email my patients and ask them how their blood pressure is or follow up. But what I don't love is when it's on top of all the other regularly scheduled duties. So I think that we need to make messages a valued, compensated form of care, just as valid as everything else, and it needs to be given its time and compensation. Let's also just say, for example, what about if Ms. Jones, instead of picking up her phone and talking to Charlie, maybe she writes a real long message detailing all of those concerns, and maybe Emily, the EMR AI, analyzes that and goes, 10% chance of ever resolving this over message. We need to make this a visit. And you'd like to think that your clinical judgment would tell you that up front, but sometimes you don't know, and you get drawn into these back and forth conversations, and eventually you kind of realize, we're in a morass here, and I just need to see this person and speak to them face to face and lay on hands and that kind of thing. So that would be really cool. However, it's also not all about text. So I do think that humans are still in charge, and we need to take some different actions of how we deal with the inbox. I think we need protocols about how to communicate. We shouldn't be, as providers or physicians, cutting and pasting a big jargon x-ray report, asking the MA to call the patient and read it verbatim and just think it's gonna go fine. It's not. The patient's gonna be like, what? And so we need to translate those things into human language, or maybe Emily needs to help us do that, the AI, and then we edit and approve her response. I think we also need to stop writing word clouds, which providers are known to do, where we receive a question, we write a message back that's like all of this kind of thoughts off the top of our head. We could be a lot more sort of clear cut about, if the patient's doing this, recommend X. If they're doing that, recommend Y, that kind of thing. Now, this slide may be a little bit controversial, perhaps, and we don't need to dwell on it in too much depth, but I do think that patients have room to step up their side of the partnership a little bit. And sometimes we bend so far over backwards to accommodate patients that, again, it causes a lot of burnout, and we don't even necessarily treat them with full respect, like a full adult that's an equal partner in what we're doing here. One example of that, and this happened to me when I went to my doctor just a couple weeks ago, is actually not knowing how long your visit is. So I've alluded to how running late is really stressful, but if the poor patient doesn't even know, is this a 20 or a 40-minute visit, because nobody says that during the entire process, well, they might just want to keep on talking and think of something else and bring it in, and it kind of all makes sense. But if we respect the whole process, we would be clearer, for example, about that. Now, of course, there's limitations. There's different levels of health literacy. I do think, though, that Charlie can help people with their health literacy, understanding the system, how to navigate it, what to expect, coming prepared with their own questions, for example. It would be really cool if people had, to the points about like owning your own data more, a little bit more of an understanding about what's already been done. So I can't tell you, and I'm sure the physicians in here can relate, how many times I've been doing a ton of stuff with a patient and they give me this huge swerve and go, I wanted to talk to you though too about my abdominal pain. I'm like, oh my God, the abdominal pain, okay. All right, when did it start? Does it radiate? What is it like? And I'm asking all the proper questions while I'm also furiously going through the chart, trying to figure out what's been done. And I might find they have had a CT scan, they've seen GI, they've been scoped from above and below, they've tried Prilosec, and they've had labs. And that might take 20 minutes of both simultaneous conversation and furious work in the EMR, very draining emotionally. And really, I'm hoping with Charlie and Emily and the patient as a more full partner in this, we can avoid that, and we can actually have more of a conversation like, I'm still having abdominal pain. After all of these things have been done, I wonder what your thoughts are about that. And that would be a lot more efficient, frankly. Okay, and I won't go too far into threats and violence are unacceptable, but this is obviously a huge thing that we're dealing with clinically based on societal sort of behavior changes. Okay, last pillar, supported by tech. So one of my theses here, and I think you're getting the idea, is that since some of our problems in medicine were created by tech, tech will have to be part of the solution. Okay, I don't think we can fix the problems of today with paper charts, for example, or the tools of the past, much like you shouldn't bring sandals to a snowball fight, so to speak. I also think that with the push towards value-based care and metrics and outcomes, although again, I love that personally, and I think it's much better than fee-for-service for actual patient outcomes, it is a huge cognitive burden, and it's a huge data burden. And so we're gonna need Emily and the doctor, and we're gonna need dashboards, and probably other members of the team as well, managing all of that. I think we need risk prediction scores for allocating our scarce resources. So some examples, let's say one of those connected scales for a congestive heart failure patient detects that the patient's gaining weight. So those numbers are transmitted to Emily. Emily alerts either Charlie, the other chatbot, or the nurse to call the patient. Using a protocol, they go through what are the reasons for that. Are you eating more salt? Did you have a big celebration and go out to dinner? Did you run out of your diuretic prescription because of a pharmacy issue? And then maybe there's a protocolized response, like either you need a visit, or yep, you are on the diuretic, we need to up the dose for a few days and then follow up. So hopefully we can prevent that becoming an ER visit for a decompensated CHF. For example, as well, hospital discharge, perhaps a patient is deemed to be high risk for readmission. This is such a huge quality metric that we follow. And if we could proactively give them more support as they transition to home, troubleshoot whatever problems they may be dealing with prescriptions or DME or other things, and prevent that ER visit that then becomes a readmission. Again, I think that we're gonna both prevent costly harm events, save money, and then of course we'll need to use some of that money to fund the transition to clinic of the future. Okay, but it's not all rainbows and unicorns, right? Sounds really nice the way I'm presenting this, but this isn't in fact all straightforward. And so I put up here some common objections. Okay, and I will go through them quickly because I'm getting close to time here. And so you guys are probably familiar with this and how you encounter AI in your professional or personal life too. But suffice it to say, without addressing every single one of these, the kind of bottom line is that it's a new emerging tool and we're gonna have to stay vigilant. And we know it can hallucinate. We know it can make errors. We know there are unresolved issues of liability when it makes an error, if it's not properly sort of being caught by a human who's responsible for that, who gets sued, who loses millions of dollars. We're gonna need to basically stay vigilant, don't fall asleep at the wheel. But I also think that we're stronger together and that we need this to deliver the standard of care that is being required today. Maybe we'll go real quick through this. This was actually nicely introduced by Paula, so direct primary care. This is the second part of my to be sure, or objections perhaps, to Clinic of the Future. This idea is the antidote to complexity is simplicity. And there's a lot that's really appealing about that, and I think that there will be room for this in the healthcare ecosystem. I wonder about scalability, so probably Paula and I should have a meeting and talk about that. I'd love to hear your thoughts about that, honestly. And sort of how can we practice in the future without leveraging tech? Not that they don't leverage tech, but these like bigger population panels and outcomes and whatnot. Worry about scalability, etc. Okay. So how can we evolve towards this? Again, each one of these could be a long conversation, but probably the biggest thing is use AI in our own lives, and I think that probably this whole room is doing that, and even ahead of me. In clinic, trying out tools like the scribe and asking for more, building trust within our teams, talk about clinical protocols, talk about the inbox, reframe patient expectations. Haha, I say that like it's easy, and I've been actually working on it for 20 years. And then, asking leadership if they have a roadmap into the future, and then if not, call me and I'd love to come in and consult and help have that conversation. So essentially, my thought is that, again, this is a difficult moment, but there's huge opportunity if we can step up to it. Change is inevitable. Let's let us be in charge rather than having it be done to us. And if this resonates to you, reach out and let's chat. So.
All right, any burning questions for Holly?
Please.
That was excellent overview, Holly. Thank you very much.
Thank you.
You got to it in the end, and we use AI a great deal, obviously, and our trust level is very low. And so we do have scientists go through it. And one of my favorite quotes is that I love AI for the things I don't know, because it helps me, but it really is not that accurate. So are you confident enough now to, I guess in certain parts of your
maybe.
practice?
I'm gonna say maybe, and what I mean by that is that I use AI in my personal life, but also medically with primarily open evidence. So, and when I read open evidence, it's kind of like I know what's right in there and what's squishy. And maybe that is because of a couple decades of being around the block in medicine. But I definitely can identify the parts where it's not that it's making things up, but it makes it sound like it's current. And then if you look at the reference, it's from 2013. Even if I said latest guidelines for treatment on X, Y, or Z. So yeah, I don't think that it's certainly not ready to fly without oversight. And I think truly we're always gonna need to be overseeing, always. Yeah, great point. Yeah.
20 years ago, I came from India, background in clinical medicine. Think of it as Sherlock Holmes and Dr. Watson. My US peers were ordering tests. clinical medicine and clinical insight is generally people who have gray hair and look around. What happens to the doctors of the future? Like, what does doctor education look like for, you know, people who are entering med school now? Given that you have to be an expert to understand whether AI is right or not. Where do you think they're going to get their clinical experience from so that they can actually judge whether AI is right or not?
Yeah, I mean, I think it's a great question. I worry about that. I do teach internal medicine residents up at Legacy Health in Portland, Oregon. And so I literally had a big talk about AI with them right before coming down here because I told them I was doing this. And they had very different takes on it. And yeah, I think that we need to stay grounded in the basics. So we need to do what I'm doing with them, which is precepting. Talk about, okay, the differential diagnosis, what else could we have missed? Oh, we don't exactly know this one thing. Let's ask open evidence. We look at it together, you know. So I don't know that there's a magic answer to that, but we certainly can't give their education over to AI because I think within a few years to a generation, we'll have major erosion of knowledge if we do that. But I think that, yeah, the folks that have been doing it for a while need to stay engaged. And we need to train them about what to be skeptical of. Like, I was at another AI lecture where it said basically they're bad at timelines, LLMs, and that helped me understand why I was getting this fuzziness in open evidence sometimes where it was more confidently saying it knew the latest guideline than it really did. So I think education about the pitfalls, I've heard also, maybe you have as well, math not magic, you know? It's math not magic. And so actually having lectures about the underpinnings, how an LLM actually works, not maybe too technical, but where the major pitfalls are. But I think we have to be vigilant. We have to remain vigilant throughout this entire process. Yeah.